We are live, you may start.
Yes. Okay. So moving on to the next session of Global Interdisciplinary Summit 2020. Again, a power pack session. So Global Interdisciplinary Summit and GOMA are correlated and joined for this session. So with the introduction of GOMA, I'll move on to, it's a global organization representing medical and health profession. It promotes and provides accreditation, certification, education, training, and other resources for organizations, professionals, students. The Global Outreach Medical and Health Association has firmly established a leadership role in medical and health sector. So before moving on to the session, I would like to give a few key points for the participants that whether if they wish to have their participation certificates, they need to have their GOMA membership. If they are not having a GOMA membership, kindly register to www.gomha.org. And the link will be shared to all the participants in the session, in between of the session, where they have to fill a form. And the form will be valid only for 2 hours. Along with that, you need to present a screenshot of the seminar, which will be acting as a proof for all the participants. So after the submission of the form, the certificates of the participants will be directly mailed on to them. Moving on to the speaker of the day, Dr. Samvel Bleyan. Dr. Samvel is a dentist with extensive experience in oral surgery, prosthetic rehabilitation, and aesthetic dentistry, and an international speaker. He focuses on advanced bone grafting techniques, soft tissue rehabilitation around implants, with the goal of harmonic environment with final restorations. He received his dental honors degree and completed his residency in prosthodontics at the Yerevan State Medical Institute with honors. He earned his MBA degree at American University of Armenia. Dr. Bleyan is a frequent presenter on topics such as total site optimization, socket preservation, immediate implant placement, and advanced hard and soft tissue grafting techniques. So with this, I would like to welcome Sir, and the stage is all yours.
Thank you so much, and thanks to all organizers of this great event. I hope that you will enjoy today my presentation, the topic of which is soft tissue management around the implants. And today we'll talk about how to manage soft tissues around implants and how to get ideal results with our prosthetic rehabilitation concerning pink aesthetic. So let's go ahead. Dental aesthetics defined as achieving a pleasing appearance of dental restoration in harmony with surrounding teeth and tissues. In general, that implies mimicking healthy dental structures and surrounding them with healthy soft tissue in a natural and harmonious fashion. This is the overview of everything we will talk about today with the topic concerning the soft tissue around implants. Let's see on the case presented here. This is two laterally missed incisors, which we prepare to place implants. We make an orthodontics. And after creating enough space, we're going to place implant. The implant was placed with some bone grafting, and after 4 months, we ready to go to prosthetic part. As you see, we place here zirconia abutments and restore the tooth. On the first glance, it's looking very beautiful. I urge to take attention. The work was done 12 years ago. And this is the final view of the restoration. It looks very pretty. The patient was very happy, and this is the closer view, and it looks very harmonic. It's difficult to say that there is some problems. There was some problems here, and it was implant restorated. But look at the area above the lateral incisor. As you seen there, there is concavity which talks about a missing teeth, and This approach, which I used 12 years ago, was changed dramatically since that. I changed a lot in my approach for such cases. Except bone grafting, now we have to think about the overall appearance of the restoration, not only the ceramics and the surrounding tissues, but the overall pictures. Look at the other case. This is 2012. And I placed the implant and immediately and restored it later, 2-3 months later, with definitive crowns. And look how it develops during 8 years or so. You see that we have a very beautifully organized gingival cuff around the implants, around the crown, which is one of the prerequisites for long-term stability of the implant and the restoration and the appearance of all this process. Soft tissue implant interface is an important anatomical feature contributing to the long-term success of dental implants. So if 15 years ago we think mainly about integration of implant and maybe creating enough bone for placing our implants, nowadays we change our approach. Not only the bone, but the soft tissue is very essential part of our rehabilitation, of how it will look like after delivery of final restoration. So soft tissue which surrounds the transmucosal part of dental implants, we called it peri-implant mucosa. It separates the implant from the bone around the implant from the oral cavity. And there is some differences, and we will talk a little bit about that. Look, here on the right side, we see the biological width, so-called biological width of the soft tissue with the implants and with the tooth. And there is some differences. We see that the height of biological width is about 4 mm around the implants and about 3 mm around the tooth. And we can talk about this soft tissue seal around the implant as a biological barrier against microflora which can invade into this space and afterwards create some problems like perimucosa, inflammation, mucositis, and peri-implantitis. But we will show with the slides how we can get some seals between the titanium or zirconia surface and the long junctional epithelium. And the difference between these two pictures is in junctional epithelium. That is why a long junctional epithelium is present here with the implants, and we have not such type of structure in the tooth cases. So what we call the biological seal, it's the cuff around, it's the soft tissue cuff around the implants, which prevents the development, as I say, peri-implant diseases. So the soft tissue seal around the implants ensures healthy conditions and stable osseointegration, and therefore also a long-term survival. This is the main principle and the most important part of our soft tissue rehabilitation. Once again, peri-implant mucosa has a comparable potential as the gingiva around the teeth to prevent subgingival plaque formation, which may cause subsequent infection. And when we explore the nature of soft tissue around the implants and around the natural teeth, we see that there are some differences. And these differences mainly concerning the direction of the collagen fibers. In case of natural tooth, it's on different direction. You can see here that we have different types of collagen fibers which goes from tooth to tooth, from bone to tooth, and support the soft tissue structure around the teeth. And in case of implants, we have only fibers which are directed parallel to the central, parallel to the titanium surface. So this is very important thing. It's less stable than around the natural teeth. That is why we have to think about creation of enough soft tissue thickness, height, and width to be able to support this peri-implant seal. Otherwise, in the case of not sufficient height and the thickness of the soft tissue around the implants, we will get some problems. And these problems are related to the other things. We have to remember that around implants, we have only mainly one source of vascularization. The gingiva is itself a little bit from, and the second origin is the crestal bone. But in the case of natural tooth, we have a very powerful source of vascularization. It's periodontal ligamentum, which we don't have in case of natural tooth, and it's very important. So to make soft tissue stable in case of not sufficient, not so good vascular supply, we have to create enough space for collagen fibers and for vascular plexus, which will ensure the healthy condition of the soft tissue. So, and the second factor which influences the long-term stability of soft tissue around the implant is the zone of keratinized gingiva. For many clinicians, the question, do we need to have a zone of keratinized tissue around gingiva is obvious. We have. But the literature said that there is no direct correlation between the peri-implantitis and the absence or presence of keratinized tissue. But from the prosthetic point of view, it's very obvious that having enough width of keratinized tissue around keratinized gingiva around the implants allows us to prevent collection of the plaque around the implant neck. And it makes much more easier for the patient to control this plaque around the implant. And that is why it may prevent the peri-implant disease. The literature said that there is only one correlation between the presence of keratinized tissue and some recession around implant neck, and nothing more. There is no any evidence of direct correlation between inflammation of the gingiva and peri-implantitis and peri-mucositis around implants with the absence or presence of keratinized tissue, gingiva. So in any way, I think that having wide enough keratinized zone around the implant is very important to create the stable soft tissue environment around our implant. So, as I said, there is no direct correlation, and here is the review of literature by Buchler and Frey and Burkhardt, who talked about the importance of keratinized tissue around the implants. So now we have to go to some other literature, the other articles. The group of dentists from Lithuania under the head of Tomas Linkevičius has a lot of articles, and they continue to work on the question, what is the reason of peri-implant bone loss? And they suggest the concept of zero bone loss, which relates to the amount and the thickness and the quality of soft tissue. And they suggest different way to create and increase the soft tissue. And in all his articles, Linkevičius and his colleagues shows that the presence of enough height of soft tissue above the implant neck is very important to prevent peri-implant bone loss. And in this article, as I say, they said that having at least 2 millimeters of soft tissue above the implant neck will lead inevitably to a loss of 1.45 millimeter of bone, so-called remodeling of the bone around the implants. And from where this data came? As we said previously, biological width, so we have to understand the biology. Biological width is about 3.8 millimeter. And if we have only 2 millimeter of the thickness of the soft tissue above the implant, it means that the biology will take the space, and this space was taken primarily from the bone surrounding the implant neck. And that is why we see very often so-called remodeling around the implant. And now Suppose that in the literature, we see that at the first year after attaching abutment to the implant, we lose about 1 millimeter of the bone. And then consequently, every year, it may be about 0.2 millimeter. Now, when we talk about long-term survival of the implants, suppose that after 10 or 15 years, we will get about 4 or 5 millimeter loss around of the bone around the implant, and it not state that this is the parameter of long-term stability and survival of the implants. That is why we need to create enough soft tissue and enough thickness and width of soft tissue around the implant to prevent this remodeling, and that is why to prevent possible loss of the bone. The other article with Linkevicius and colleagues said that it can be concluded that implant with platform switching didn't preserve crestal bone better in comparison with implant with traditional implant abutment connection, if at the time of implant placement we have only we have a thin mucosa. So very often we told that switching the implant platforms may prevent bone loss around the implant. Yes, it may, but in case of thin soft tissues above the implant, it will not allows us to keep the bone level on the level of the implant implant platform. In case of course, when we place implants on the level of the crest. And the result of this study indicate that altered horizontal relationship between the edge of the implant and small diameter abutment doesn't prevent crestal bone loss. Once again, if mucosa is less than 2 millimeter. So he has the other very interesting article, influence of vertical soft tissue thickness on crestal bone change, where he said that platform switching doesn't prevent crestal bone loss. And in case of thick soft tissue, use of platform switching implants maintain crestal bone level with minimal remodeling. And you can see on the table, this is the group with thin, the first group is the group of thin mucosa, and the second group is the group with thick mucosa. And you see that mean loss of the bone around the implant in case of thick mucosa is about 0.22 millimeters instead of 1.80 millimeters after a year of connecting abutment to the implant. Once again, and the last one which I want to present, influence of abutment height on maintenance of peri-implant crestal bone at bone level implants. After the 3 years of study, they once again stated that when we have the height of the abutment less than 2 millimeters, it means that we have thin tissue. We will have inevitable bone loss. And in the case of the abutment more than 3 millimeters, it means the thick tissue, we have the minimal loss of the peri-implant bone. So this is the main slides of my presentation, which I borrow from my colleague Jorge Campos Aliaga from Spain, which make the overall situation more clear. Look, on the left of the slide, we see when we have only 1 millimeter of soft tissue thickness, we have to place implant on the depth of 3 millimeter to keep 4 millimeter of biological width. And in the case of 2 millimeter thickness, we will have only we will have to put the implant deeper only for 2 millimeters to keep this 4 millimeter biological width. And the second one, the third one is when we have 3 millimeter of the thickness, we can place our implant on 1 millimeter depth about under the crest. And only in case of 4 millimeter of thickness, we can place our implant epicrestally. Do we have always the thickness of soft tissue above our implant 3 millimeter? Of course not. That is why, generally said, what we have to do, we have to either increase the thickness of the soft tissue along with the placement of the implant to ensure 4 millimeters. And in this case, we can place the implant epicrestally. Or at least we can place implant, which I usually do, with the platform switch, by the way, connection, conical connection, only 1 millimeter deep in the bone and providing 3 and maybe a little bit more 4 millimeter of soft tissue, and I will show how we perform all the procedures. There is different way to increase the thickness and the volume of the soft tissue, and this is the main, once again, main slide of my presentation. Remember, please, and this is very important, in case of thin mucosa, if you place your implant on the level of the bone, you will lose another 2.83 millimeter of the bone, like in the case of the left situation, the first one. And only we can place the implant without doubting that we will lose some bone around the implant. We need to have 4 millimeter implant. This is very important. Now, as I say, 4 millimeter of the thickness of the soft tissue above the implant is the minimal amount which will prevent the loss of the bone, so-called remodeling. And at the same time, I usually create about 3-4 millimeter at least of the width of keratinized gingiva to facilitate proper plate control and to be able to keep the pink aesthetic on high level. So, volume of the soft tissue and the width of keratinized gingiva. This is the main things which we have to remember. And by the way, look at this abutment shape. This is the most appropriate abutment shape. It is, we call it tulip shape of the abutment, which allows us to keep as much as possible the thickness of soft tissue around the neck of the implant, with the help of which we can ensure enough volume for soft tissue, which have enough collagen fibers, which will keep the volume of the soft tissue stable around the implant. And of course, as I say, you can see here on the X-ray how it looks like. It's the ideal situation when we place implant a little bit deeper than the crestal level and create the restoration with tulip-shaped abutment, which allows us to keep more soft tissue, less titanium or whatever. Okay, and the overview of what we will see today is here. It's the connective tissue graft, it's vestibuloplasty, it's a free gingival graft, apically positioned flap, rotated pedicle vascularized flap, roll technique, modified roll technique, tunnel technique, and PALATE technique. There are 2 types of free tissues autografts. It's a free subepithelial connective tissue graft, which we use to increase the thickness of the soft tissue, and free full thickness mucosal graft, which we use to increase the width of keratinized gingiva. And there is difficult techniques, and the most well-known is the one incision technique, which well described with Zur and Hülserl. The history of this technique is since 40 years, 30-40 years. And it supposes one incision, then make a superficial incision above the under the 1 millimeter thickness vestibular outer flap, and then we make 2 vertical and 1 deep horizontal incision to take out the graft. This graft has its advantages and disadvantages. We'll talk a little bit later about that. And the advantage of this technique is less morbidity, because we're able, as you see here, close the wound. But the quality of the soft tissue which we get is, in my opinion, a little bit compromised, because we collect a lot of glandular and adipose tissues and less connective tissue. But first of all, we need connective tissue, which will keep the stable volume of the grafted zone. So here, this is the slides of my good friends from Armenia, Zakarian Khoren. He gave his slides to me to show how he performed this procedure. And you see that after the making first incision, we go into the palate parallel to the vault of the palate. We have to ensure 1 millimeter or a little bit more thickness of the soft tissue. Usually we get this connective tissue graft from the zone of the first molar to the zone of the first premolar. If we need more length, we can go to other side of the palate or to extend the length of our incision. Then we go with 2 vertical incision on the border of the incision inside of the flap to detach the inner part of the soft tissue from the bone. Then with the elevator, we detach the graft from the bone and take it out. Then we suturing, that's it. Easy procedure, and it's very well described in different literature, and you can look at Hurzeler Zur textbook, which is very, very important for everybody who want to work properly with soft tissue. And the second technique, which well described in this article and suggested by Dr. Zucchelli, this is full thickness graft, which we take from the pellet and then deepitalize it afterwards. This technique has the great advantage that we got 100% quality of the connective tissue without any signs of adipose tissue, and many people said that it's traumatic, but if it performed properly, so if you keep just 1.5 millimeter thickness, because we need usually 1 millimeter, 1.5 millimeter of the graft, then the post-operative morbidity will be minimal. And from my experience, I just gave my patient only 1 pill of painkiller, and on the next day they are good. You will see how it works in my hands. This is the technique of Dr. Zucchelli. When we take our connective tissue graft with the making incision, rectangular incision, you have to remember that we have to always overlap the incisions to be sure that we properly collect the graft. Then we this is the graft. We deepitalize it on the wooden pad. Take out the 0.5 millimeter of the thickness of the epithelium with 15C blades, and this is pure connective tissue graft. As you see, there is no any sign of adipose and glandular tissue, and it will stay. It will not shrinkage. It will work very well to increase the thickness, and it has the potential to grow. It means that you will not lose the volume of the soft tissue, but you can gain, and you will see how it does work in my slides. And it's very flexible. You can suture it whenever and wherever you want. You can put it in the tunnel very effectively, so it works very well. And so there is two regions where we collect this type of graft from the pellet. This is the anterior pellet and posterior pellet. And the thickness of the palatal soft tissue is about 4 millimeters, 3.5, 4 millimeters in this zone of from the first molar to the first premolar. And we have to remember that depending on the type of the pellet, it may be a high pellet, regular and shallow pellet. We have to remember about the greater palatinal artery. If we keep our incision on the border of connective tissue and soft tissue and glandular tissue, I mean, on the pellet, you will never damage this greater palatinal artery. And the mean distance from the marginal edge of the soft tissue near the to the great palatinal artery is about 9 millimeters. You have to remember this, 9-11 millimeters. So take into account this. The other place where we effectively can graft soft tissue is the tuberosity. Sometimes we don't have enough soft tissue there. There is the way how to deal with this situation. Sometimes we need to take out the wisdom teeth, wait some 4 months until we get enough tuberosity, thickness of the soft tissue in tuberosity, and then continue our standard implant procedure. And the advantages of this type of graft is it's very stable. Of course, there is disadvantages that it's less vascularized, but the other advantage is it's not able to shrinkage. So this is very important. You will never lose the thickness of the graft, and it also, depending on the type of incision, has an opportunity to grow, which is not so good. And you will see in one of my cases how does it work. Of course, it's less painful, so I mean less morbidity, and we don't need any protection of the zone. One thing we have to remember, this type of graft, we need to cover totally with the corneal advanced flap to be sure that we will avoid any necrosis. This is very important. In case of one incision technique, sometimes we're able to to keep about 1.5 millimeter of the connective tissue graft exposed. Part of this graft will go to necrosis, and the other part will survive. With the graft from tuberosity, it's impossible to survive if it's exposed in the oral cavity. And this is the technique which very well described in the above mentioned books of Dr. Hurzeler and Zur, how we make two parallel incision inside of the soft tissue at the zone of the tuber. Then we make a partial thickness incision toward vestibular and palatal flap and take out our graft. If we need, we deepitalize it later. If not, sometimes we use such type of graft you see here to cover our extraction socket after the grafting when we make socket preservation. Okay. And we will talk about the usage of connective tissue graft in the case of one-stage implant placement, which very tricky procedure. And we have to remember that we need some prerequisites for making this type of procedure, and one of which is good quality of the bone, so we may be able to get primary stabilization. Sometimes we need a little bit graft in the gap between the implant and vestibular wall of the socket, sometimes not. We can measure the stability with ISQ system, implant stability quotient, like ISQ or OSTEL. And we have to have enough zone of keratinized tissue and thickness of the soft tissue. So one of the problem with immediate implant placement in the aesthetic zone especially, we have to have good biotype, so thick biotype of the gingiva and not scallop gingiva. Otherwise, it's very non-predictable what we'll get after the implant placement. So the result may not be predictable. So one of the prerequisites is having a good quality of the bone, enough bone at the top of the socket, and good quality of soft tissue surrounding the implant. Look at this table. Depending on the position of the implant in the socket, we may graft the soft tissue to preserve and to keep the volume of soft tissue in its place, depending on the position of the implant in the socket. In case of ideal cingulum position, we don't need tissue grafting. We perform grafting the gap between the implant and vestibular plate with non-resorbable xenograft, and that's enough. It's Dr. Salama's idea of dual zone grafting. Then we place our temporal restoration, which will keep the grafted zone and soft tissue in its place and keep the contours of the socket on soft tissue. In case of position of the implant with regards of the incisal edge, so when we place implant with the abutment aperture on the incisal plane, we need to graft the soft tissue around the implant to protect and to keep the enough volume of soft tissue. And the third one is the one when we see the implant placed too buccally. In this case, it's impossible to ensure to prevent the recession. It will inevitable, and we will have some bone loss. So in the case of placing and having the implants out of the bone envelope, it's a good idea to extract the implant and make a bone grafting and then return and place implant in the correct position. Let's see at this case. This is one-stage implant placement with connective tissue graft. This is the first tooth number 1-1, the first right incisor. We extracted. There is a granulation, big granulation above the root, so we clean totally. We rinse it very thoroughly. We have to ensure that there is no any signs of inflammatory tissue there. Then we make our initial osteotomy on palatal wall to place implant in correct position. Then we make our osteotomy, place our implant, fill the gap with the bone, then take our temporary titanium abutment, create temporary restoration. Usually we have the wax up, with the help of which we make an impression on the model and create inside of the mouth this restoration. As you see, here we have the aperture of the abutment screw hole on the incisional edge. So we need to place, as I say, connective tissue. We have to shape properly our temporary crown to protect and to keep the contour of the soft tissue intact. Then we go to palate and get a small piece of connective tissue, create a little bit tunnel, and place our connective tissue through the tunnel under the vestibular flap. We can suture it in from two sides. Then we make our suspended suture, which will keep the soft tissue in proper position and don't allow it to shrink. This is X-ray with temporary abutment. We have to check that it doesn't interfere with the bone wall surrounding the implant, and this is the temporary crown. Look how it looks like with temporary crown and the final restoration and X-ray 1 year later. It looks very attractive. The other case with immediate implant and connective tissue graft, this is the temporary canine. The patient is about 40 years old, and then you see here the fistula with the inflammation and periapical lesion. We very traumatically extract the tooth. We clean everything there. We take out all granulation tissue. There is a fistula, as I say, from the apical part of the root or the socket to the vestibular part. But we create our osteotomy as well on palatal side. We check out the direction. Then we graft the defect and place our implant. And here you see that we use healing abutment as the protective measure to keep the bone and to protect soft tissue from collapsing. Then we go to the tuberosity, and there is a big, huge tuber zone there. We take a small piece of connective tissue, you see here. This is the parallel technique of incision. Then we have to deepitalize. You see the thickness of the epithelium. How much is it? This is our connective tissue graft. It's 100 totally full of collagen fibers. There is very little amount of vascular of vessels inside of the graft. That is why I said we have to always remember keep covered with the vestibular flap your connective tissue graft. Otherwise, it will be go to necrosis. Then we suture it and deepitalize our graft from the tuber. How to increase the size of this small connective tissue graft? We just divide it in two parts. It's called a butterfly technique. Then we create a tunnel and place our connective tissue graft under the vestibular flap to ensure and to protect the soft tissue thickness here and to be sure that we will have a long-term stability. And this is the butterfly technique. As I said, we divide it into two parts. We don't need to detach it from each other. We keep it together, and we can put it in any tunnel, and it will help us a lot. You see here, we sutured everything there. And this is the healing at the third day, some fibrous tissues above. It's a normal healing. This is the 8th day, everything goes well. Then we take out the suture after 2 weeks. It looks very nice. Here is the healing in 3 weeks. Everything is good. So we have no any signs of inflammation. You see the fistula is resolved for sure. Then we make our temporary crown. push the soft tissue using dynamic compression technique, then we are ready to take our impression. This is our final restoration. It looks very attractive, and the level of the bone is very stable and no any signs of any inflammation. Look here, this is before, this is after. As I said previously, we create the width of the soft tissue, we create the height of the soft tissue. By the way, width of the soft tissue support the height of the soft tissue, and we have enough zone of keratinization. Look how wide the keratinized tissue is here. Okay, let's go to other case, very interesting case with two implants, two immediate implants and socket shield. We divide, let's back here, you see we divide the first molar onto three parts and extract very carefully each root separately. You see the socket, then we degranulate it and rinse very thoroughly to be sure that there is no any signs of inflammation. Then we perform socket shield technique, which will keep the volume of the bone and prominence of the bone and the level of soft tissue around our future implant very stable. You see that we separate the vestibular part from the palatal, then we extract the palatal part, here it is. Then we prepare the socket properly, we downsize to the level of the bone, we make special curvature here to prevent the final restoration, temporary restoration from pushing the soft tissue and consequently exposure of the shield. Here you see how properly we make the design of the shield. And we make our socket grafting. We fill the gap, the future gap between the implant and the vestibular wall. Here it is. Then we create so-called socket seal abutment. This is abutment which we create inside of the mouth with the help of the flowable composite and temporary abutment. Then we go to make our sinus lift simultaneously with the place our implant. We use denser drills here. We fill the gap. We fill the socket with the allograft, mineralized and demineralized. We use both of them. Cancellous cortical bone. We have very high stability. You see, it's about 40 Newton per centimeter. Then we measure the ISQ of the implant placed at the zone of first premolar. It's 82. The second implant at the zone of the molar, the same high initial torque. Then the measurement of the ISQ is 80. It's high enough. We able to load these both implants simultaneously with temporary crowns. By the way, because the threshold is more than 70. Here we have 80, 82. And this is two socket seal abutment, which we used, of course, with the poncho technique, with PRF membranes to keep all the graft inside very safe. And this is CBCT scan. You see that this is the sinus lift, Crestal sinus lift through the socket. This is the initial height of the bone there. And this is our socket shield and the implant at the zone of first of the second premolar. And you see the gap is totally filled with the allograft. And I just want to go rapidly through the process, how we make, with the help of the special kit for socket shield, the preparation of the tooth. I have to mention that we have go until the apical part of the tooth, and we have to extract the apical part as well to be sure that there is no any infection there. This is the shield, and this is the preparation of the osteotomy. This is implant. Here it is, the temporary abutment on the implant, and we create our socket seal abutment. Then we go to the zone of the first molar. You see, this is the initial zone of the sinus floor, and this is already, we place small amount of the bone through the osteotomy inside of the sinus, under the sinus membrane. And you see how it changed. We have dome-shaped bone augmentation here, which says that there is no any type of perforation, and we keep the membrane safe. Here it is. You see very clearly, we see the dome-shaped augmentation in the sinus. We place implant, temporary abutment, and socket seal abutment. And you can see the development here, from here to here, how we put the bone inside of the sinus with the help of denser bars. We place implant and socket seal abutment. Look at this picture. It's the 9th day and 9-day post-op and 2 months post-op. You see here some signs of PRF membranes which we put with the socket seal abutment. Of course, 2 months later there is no any signs, but the soft tissue is very stable. And this is 4 months post-op. Look how beautiful we was able to create the emergence profile. And by the way, this is the zone of sockets of socket shield. And look, very interesting that there is no any type of change of the volume of the soft tissue and the underlying bone. It means that this technique of socket shield works very, very well. This is the day of delivery of the final crown. You see some deficiency of the papilla here in between the premolar and molar, but we know that it will grow up. And here it is 1 year post-op. You see that this defect is fully occupied by the papillas, and the view of the peri-implant soft tissue is very beautiful. It's stable, and we have a wide enough keratinized zone of keratinized tissue, because we don't close, we don't raise the flap and try to close our preserved socket. We keep the level of the attachment at the same level where it was at the beginning. And we have the thickness enough to be able to keep the final restoration, and looks like, very natural. Okay, and this is before and after, and you see that we don't lose anything. This is the initial shape, and this is the final shape, even more maybe here a little bit. Okay. This is the case development from the beginning to the end. And now we can go to two-stage implant placement. This is the most often what we see in our practice when people come with huge atrophy of the alveolar ridge, and we need to create enough zone of the bone, first of all, and then think about soft tissue, or maybe combine soft tissue grafting with increasing the width of the ridge with the GBR technique. Now look at this case. This is the second stage surgery when we have already placed our implants and we go to place our healing abutments. Here we performed big augmentation because the thickness of the ridge was only about 2.5 millimeter. When we raise the flap, we see that the thickness of the soft tissue, it's about 1.5 millimeter, not more. So we need to increase the thickness. As we mentioned previously, Linkevicius said that if you don't have 4 millimeter of the soft tissue above the bone, above the level of the platform of the implant, inevitably you will lose bone around it. So we make a partial thickness flap. You see, this is the periosteum. This is the vestibular the mucosa, which we split from the flap. Here it's more clearly seen. Then we go to palate, and with the Zucchelli technique, we take our free gingival graft, which we deepitalized out of the mouth. Here it is. Now we are ready to place this 1.5 millimeter soft tissue graft in between connective, in between periosteum and vestibular partial thickness flap. And here you see how it was performed very clearly, right? Okay, this is periosteum, this is our connective tissue graft, and this is our vestibular flap, which we detach it. Then we place our healing abutment and we perform PRF poncho on the our healing abutment to cover the inter-implant zone. Now, you see that we are able to suture a lingual flap with the periosteum on vestibular side, which we perform here. You see very clearly how we perform the suturing to be sure that the stability will be ensured. And then we suture vestibular flap with connective tissue graft together. First of all, we suture connective tissue graft with this flap, of course, and you see here and here these sutures. And then all together we suture to lingual flap. And this is the 3rd and the 12th days after harvesting the connective tissue graft from the palate. And you see how well it heals, and we will see the whole process of healing. In this slide, I collect all the stages from the beginning of the second stage, then how we see we create wide enough and thick soft tissue around our implants. Then with the help of dynamic compression techniques, we create a new emergence profile during some temporary crown modifications, which we perform 2 or 3 times during 1-2 months. Then we wait for 2 months for stabilization of soft tissue, and you see how beautiful we create emergence profile, how wide we have. We get the soft tissue. Compare this as this photo and this one. Of course, you see the big difference, and it's amazing. And we deliver our final restorations. It looks very beautifully. We have wide enough zone of keratinized tissue, and the thickness and the height of the soft tissue is well enough. The other case of connective tissue graft, we performed the same procedure. I just will not explain the situation. Here we performed ridge splitting. It was about 3 millimeters of the ridge. We create 7 millimeters of the ridge. And now we go to second stage, go to the palate, take our graft and cover it with collagen sponge. We place our X horizontal sutures. This is our graft. Then we deepitalize it. You see that there is some remnants of glandular tissue. This is epithelium. It's very well seen. And we take our epithelium out from the surface. This is the epithelium with the help of 15C blades. And this is the thickness of 1.5 millimeter of connective tissue. This is poor connective tissue. No any signs of glandular or adipose tissue there. It's very flexible. We put it under the split thickness flap and suture the same way we did previously. And this is the healing of the donor site 12 days later. And this is what we got. Very beautiful, thick, soft tissue, and it's fabulous. We create the new volume of the soft tissue. We keep the volume of keratinization there. And this is before and after. Huge difference. Only one procedure. We put connective tissue graft under the split thickness. That's it. And now we will talk a little bit about the roll technique. This technique allows us to cure small soft tissue deficiencies. First of all, we make the epithelialization before making any incision with the round diamond bar. Then we make our papilla preservation incision, and we raise the flap. Of course, our incision should be placed far palatal to be able to collect all this tissue and put it under the vestibular flap. We roll it under the vestibular flap. Then we suture in from one side, then we go to the other side. We place our healing abutment, and then we place our vertical mattress modified suture to approximate these flaps together. And you see how we suture our roll flap under the vestibular flap with the help of this horizontal mattress suture. And then we place 2 vertical mattress suture to approximate flaps together. This is the photo after performing the procedure. And this is the healing after 3 weeks. Now we are ready to deliver, to take the impression, deliver the final restoration. You see how much soft tissue, what the great volume of soft tissue we get here. And it will be very stable. Look, this is our new emergence profile. I just want to show how we change from here to here with the help of this dynamic compression technique, but just adding flowable composite on our neck of the temporary crown. We enlarge and create appropriate emergence profile around our implant. And this is just briefly the technique how we properly, precisely transfer the outlines of our soft tissue to the laboratory to be sure that our final restoration will be similar to what we create and to the shape of our emergence profile. And this is customized open train transfer, which we just get with the help of this technique. And this is our impression. You see that here we see the same outline like here in the emergence profile, and we don't lose any information. So the technical laboratory get full picture of the situation. This is before and this is after. Look, this is the depression of soft tissue, and we have the prominence of soft tissue after performing just one simple procedure. And this is final crown, which we delivered. The other technique, which we call modified roll flap technique, we just not go only with two perpendicular incision. Our incision on palatal side goes deeper. We go just around here to collect partly connective tissue graft from the palate. And you can see here the type of incision, the papilla preservation incision, as you see. Then we go with the blade a little bit deeper, about 2 millimeters deeper than the edge of our palatal incision, to get connective tissue graft from this part as well. And here you see, this is the part which we get from the palatal side. So the reason to increase the thickness, this is the part which we get from, it's about 2.5 millimeter, and it's thick enough to enlarge the volume of soft tissue. So that is why we called it modified, because we go to palatal, under the palatal flap, to get some connective tissue from there. Then we place our implant, we create our osteotomy. This is the flap we rolled under the vestibular, and this is the horizontal mattress suture with the help of which we make our procedure. So we roll the flap and suture it. Then we place our implant, and we suture these small vertical incisions with the 6-0 Rolem sutures. It has to be removed 3-4 days later. And then we are ready to place our healing abutment. And this is how it looks like after the delivery of the implant with healing abutment. This is the third day after the surgery. Look how great volume of soft tissue we get. This is, of course, a little bit necrosis, but it will heal very well. And this is 10 days. It's almost healed. And we see the great volume of soft tissue which we get here. And this is the other view. The case is in progress, so we will show later the result on my Facebook page. So we can talk a little bit about PALATE technique. Dr. PALATE is a good friend of mine, and his technique is very, very interesting. It helps us to keep the inter-implant papillas and to create these papillas, not to get the depression of the soft tissue here in between, especially in the case of adjacent implants. You see how we make these semilunar incisions, but we have to remember that we have to have at least 4 millimeters of soft tissue to keep the keratinized tissue enough on vestibular side, but not less than 4 millimeters. Otherwise, you will lose zone of keratinization. And here you can see how we make these semilunar incisions. Then we rotate it in between the healing abutment and suture all together. Everything like on the slide, on the scheme, you see the procedure: incisions, rotation, suture. And this is how it looks like. We create the new papillas in between the implants, and you can now push it with a temporary crown to create desired emergence profile. And there is the case, very interesting case, by the way, how we make this procedure, but I just a little bit modified it with, we make semilunar incision on the palatal side. You see, this is the second stage surgery. It was a very difficult case. We performed it more than 1 year. We take out our cover screws. Now you see that the incision was performed a little bit palatally to keep the volume of keratinization as much as possible on vestibular side. So we push the soft tissue from here to vestibular side, then we make our semilunar incision, rotate it and suture. Just let's look at it. This is our semilunar incision. You see here, 1, 2, 3. And we just suture it together and waiting until it heals. This is the sutured flaps, and this is the healing 12 days later. This part a little bit not fancy, but it will heal well as here. And this is how it looks like 4 weeks later. You see, everything is clear. we have enough zone of soft tissue around our implants. Now we are ready to push the soft tissue to create the proper emergence profile. This is what we get after all these procedures, and you can see how beautiful it looks like when we deliver our final restoration. The X-rays here, this is before and after, and it's very different. It looks like different cases, but it's of course the same cases. Why we get such type of result? Because we push our soft tissue from palatal side, we make a so-called apical position flap, and we perform simultaneously the other procedure, PALATE technique, to create interdental papilla. Here is what we get at the end of the procedure. Okay, there is the other case with which resembles to modified rolled palatal flap. This is the case of two adjacent implants. On the picture, you see the initial situation when we began. Then we make our implants, we create the bone and all this stuff. And look, this is partial thickness flap from the palate. We make incision only 1 millimeter deep, and then go parallel to the palatal vault to keep 1.5 millimeter of palatal soft tissue. Then we need to take out this connective tissue. This is very thick. Look here. And then we have to rotate it on vestibular side to increase the thickness of soft tissue and to prevent this depression of soft tissue here. Okay, let's look at it. This is very thick. It's more than 2-3 millimeters. Some signs of glandular tissue. This is our implants. And we put a little bit more bone on vestibular side. And this is our connective tissue graft. You see, we rolled it out under the vestibular flap. And this is PRF membranes around our healing abutment. And look, this is after the total healing of the site. 4 months later, we are ready to go to final restoration, and it's already looks like very beautiful. We keep the volume of keratinization around our implants, and we got enough thickness. It's more than 3 millimeters. You can see here and here. And this is the final restoration, which this is temporary, by the way. And after modifying soft tissue, you can see clearly that we have wide enough soft tissue. The height and the width of the soft tissue around the implant is well. It's very good. It's beautiful. And now we deliver our final restoration. We keep everything there, and it will be stable for very, very long period of time. And this is X-ray at the moment of delivery. And this is our crowns. And as I say, our crowns has to be prepared and created in the way to support soft tissue to be able to keep it in its place. And this is before and after. You see huge difference, big difference, right? The other case, very interesting case of two delayed implants. This is the first and second molar of the lower jaw. We extract it, we make an immediate implant placement. No, at the first moment we perform, sorry, not this case. Here we perform socket preservation. We cover it with PRF membrane and suture it up. Then 4 months later we return, we make CBCT scan, we plan our implant placement, and here it is. We raise the flap. Look how beautifully we preserve the reach. We make our osteotomy and place our implants with the healing abutments. And you can notice this is the 5 millimeter height of the healing abutment, and it's totally covered by soft tissue. It means that the thickness of soft tissue here will be at the end of the procedure well enough high. And you can see the thickness here. This is the way. And how we get this thickness? Because of placing, and when we make a socket preservation, we place PRF membranes there, which protect and help the healing of soft tissue. And here it is what we get at the end when we take out our healing abutments. It's about 4 millimeter, maybe more, height of the soft tissue, and thickness of the soft tissue is beautiful. Then with the help of the dynamic compression technique, you see the added part of the temporary crowns, which we add with the flowable composite. We push out in specific direction our soft tissue to create this type of emergence profile. Did you like it? I think that is beautiful. we even create interdental, so-called interdental papilla, right? And this is what we get at the beginning, after the healing, and after the compression technique, we create new emergence profile. And this is final restoration, which we delivered with a length of the keratinized tissue, with the thickness properly designed, and with beautifully created and modeled final restoration. And this is X-rays after delivery. And now we can say 2 years later, 2 years follow-up, there is no any type of changes of soft tissue, and the level of the bone is the same as at the day of delivery. So this is what we call zero bone loss concept. And of course, we will talk a little bit about tunnel technique. I think that I exceed a little bit my time, but I will be very short because I want you to show some pair of cases with free gingival graft. So you see the cleft defect here at the zone of the second, or maybe this is the zone of the canines. So we go to the palate with the technique of parallel incision, take our graft, then here it is, then we need to deepitalize. This is the zone of epithelium, which cover this connective tissue graft. You see the quality of the tissue, it's fabulous. Then we make a tunnel here, and we place our connective tissue graft under the vestibular flap. Then we suture it, wait, and look. Here, after 1 month of healing, we get very different picture. We totally restore the volume of the soft tissue here, and you can compare before and after. There is no any type of cleft there, right? That's the tunnel technique, which sometimes we can use with connective tissue grafts. And here is just for show some before and after what we can create with the soft tissue. Look here. There is no zone of keratinization, there is no volume of soft tissue, and after all the procedure and the extraction of this tooth, we create enough everything, the thickness and the height of the soft tissue. The other case, before and after. One more case, before and after. In all cases, you see that we perform the procedure which increase the volume of the soft tissue and the width of keratinization. And this is the guarantee for long-term stability, and the same is here. Okay. Let's go to some cases of free gingival graft. The technique is very easy. We make a first incision to increase the width on vestibular side. I mean, we make a first incision on mucogingival line. You will see how we do it several times in my cases. Then we perform mucosal detachment. After that, we get our free gingival graft and position it properly on recipient side. Then we connect keratinized gingiva of free gingival graft with the edges of keratinization of host place. And with the help of a single interrupted suture, we just suture the line of keratinization together. Then we suturing free gingival graft to the recipient bed with horizontal mattress or X sutures, and you will see how it looks like. And then we suture detached mucosa after the vestibuloplasty to the periosteum. That's the whole procedure. And as I say, when we take our free gingival graft, we have to totally take out all glandular tissue to be sure that the surface of free gingival graft is free of any adipose tissue, to be able to adjust to the surface of host zone, because the survival of free gingival graft goes primarily through revascularization. First of all, it's plasmatic stage when we get revascularization. Then some small vessels go into the graft. The surface of the graft, of course, get some necrotized. Then it, after the vascularization of the graft, we see that how epithelium from the surrounding places just come and cover it. Just look at this. So to prevent necrosis of the graft, we have to remember that it will be free of any dead space beneath the graft. We have to have a very close connection of periosteum to this free gingival graft. Let's look at the case. This is the beginning of the process. You see that there is no zone of keratinization and a lot of frenulums. We take out our healing abutment and perform vestibuloplasty. You see how we perform vestibuloplasty, and our recipient zone has to be free of any glandular tissue, any muscles. It has to be very good attached. Is the periosteum, of course. Then we suture our detached mucosa to the base of the vestibulum, go to the palate and take this length of free gingival graft. It's about 25 millimeters, maybe a little bit more. It's superficial well enough. You see that there is no bleeding at, after taking out the graft. It means that we keep the incision very shallow on the surface. So the thickness is about 1.5 millimeter. Then we cover the donor side with some hemostatic sponge and make X sutures. This is the accordion technique. When the length of the graft is not enough, we make such type of vertical incisions, which allows us to stretch out our graft and increase the zone of keratinization, the zone which we able to cover. And this is how it looks like before stretching and after stretching. You see that we totally cover all the zone of the recipient bed. And this is how it heals during 1st, 3rd, 7th, and 21st day after surgery. This is the day of the surgery, the 3rd day, and you see the parallel how heals the donor side. This is the 7th day, and this is 3 weeks after our procedure. The donor side is totally healed, and we get very wide new zone of keratinization. This is before and after, and I can show very clearly how wide our keratinized tissue is after the procedure, and there is no frenulum here anymore. The other case, by the way, is the case where I show you the PALATE technique of interdental papillas. This is the previous stage when we place our healing abutments, and simultaneously we put under the vestibular split thickness flap our connective tissue graft to increase the thickness of the soft tissue here. You see, this is the connective tissue graft under the split thickness flap, and this is the suture with the help of which we secure this connective tissue graft. And this is after the closure, when we suture everything together. This is the healing 2 weeks later, 3 maybe. And here we make the vestibuloplasty. You can see how we perform this vestibuloplasty to the fornix of the vestibulum. We suture it there. Then we go to palate, take our free gingival graft. It's the same site as the vestibuloplasty, not to create the new wound and to create more morbidity. We already have here some morbid sites, so we just take out free gingival graft here, cover it with sponge and suture it. This is the length, it's about 13 millimeters. We suture it to the host on the periosteum. As I said, it has to be free of any muscle parts. It should be stable to be able to ensure stability of our graft. And we suture graft here on the edge from 2 sides, and with X sutures we suture it to the healing abutments. And here how it looks like after healing. It's 3 weeks later. This, you see that the zone of keratinization is huge, and it will be stable. This is stable. This is the partly non-healed yet. Yeah, it's 3 weeks, to maybe 2.5, 3 weeks, and it heal eventually for sure. And this is how it looks like after we create our new emergence profiles. Look, with the help of dynamic compression techniques, and this is final restoration. This is before and after, and as well, great result I see. The other case of increasing the width, we will go very fast through this case. There is no zone of keratinization. This is temporary crowns. We make the same procedure, vestibuloplasty. We place our healing, the free gingival graft using accordion technique. The same is here. This is the healing of on the 3rd, 7th, 12th, and 24th day, total healing. And look at the new zone of keratinization. It's amazing. So this technique allows us to create very stable, good quality of keratinization and almost all my cases where we make some bone grafting or other such type of procedures, when we lose the zone of keratinization, or we don't have the zone of keratinization at the beginning of the process, so we perform this technique. And this is how donor site healed during the process of healing. This is the day of the surgery. The second is on the 7th day, and this is 12 days post-op. And this is the table shows us how it heals when we don't put anything there. If we just can put some glue here to protect this zone, we may create some covers, how you called it, Essex, to prevent damage or traumatization with the food. And this is the process of healing. This is the 2nd day, 7th day, 14th day, and 21st and 28th day. You see that there is no big difference how it heals with or without these protective shields. The same result. And continuing the previous case, this is the final gingival contour. As you see, the width of keratinization is huge. The other such type of case, when we don't have initial zone of keratinization, you see, this is the zone of mucogingival junction. We make our vestibuloplasty, go to palate, take out the strip of free gingival graft, suture it without any sponge, because the soft tissue here was stretchable, the thickness was enough. So we suture the strip. This is the strip technique, which well described by Dr. Urban, Istvan Urban, and we suture it to the vestibulum and to the surface of the denuded periosteum. And this is how it heals 6 weeks after the surgery. The donor site is well enough. Here, of course, you see the process of healing. This is 12 days post-op. And this is final result. Look how wide we get our zone of keratinization. And this is the side which we performed. The other side was performed with the same procedure. This is the final restoration with the width of the zone of keratinization above the implant. This is a full zirconia bridge on implant. This is one side and the other side. Okay, and the case of free gingival graft on the zone of the premolars and molars on the left side of the maxilla. The same procedure, we make vestibuloplasty, and at the same time we place our healing abutment. We perform 2 procedures. We make our palatal incision. It's not mid-crestal, it's a little bit palatal. We go to palate, take out, this is already covered, the zone of free gingival graft. We make our accordion technique, as I said. We cover our initial donor zone with collagen sponge and suture our free gingival graft on vestibular side after vestibuloplasty. Here we position it, first sutures here and here, then we suture in between, and X sutures to prevent any movement, because if you have movement and movement and mobility here, the graft will die. And this beautiful picture is what we get after the procedure. You see that there is no any signs of the donor side. It's very, well healed. And this is the new even zone of keratinized white soft tissue. Then we go to perform a modification of emergence profile with the temporary crown. You see the pontic site as well performed with this procedure. The zone of keratinization is very stable. And now we are ready to deliver the final bridge work. And this is before and after. And this is the whole work which we deliver. This is full mouth rehabilitation. Now we will talk a little bit about apically positioned flap. This is the one technique to increase the width of keratinization. When we preserve the zone of keratinized tissue, we just move it apically to be able to create the new zone of keratinization. And let's look how it works. We make a partial thickness flap on vestibular side, our first incision on the zone of mucogingival junction, or not mucogingival junction, but it's a palatally shifted. Then we keep periosteum over all the surface of this zone. We move apically the vestibular flap, suture it, and place our healing abutment. And this is how we perform it. We make the sutures on both sides and not tight sutures in between. And this is how it looks like after healing. You see that around our implants, we keep the zone of keratinization. Here, after the modification of emergence profile, it looks very beautiful. We keep the zone of keratinization, maybe not so much as with free gingival graft, but at least we was able to keep some keratinized tissue on vestibular side to be stable for longer period of time. And this is our final bridge work. This is before and after. As you see, we shift the zone of keratinization from here to here, and this big defect was healed. And the other case, the similar case, when we have the depression, of course, and we need to save the zone of keratinization, we put our incision palatally, as you see, to keep this zone of keratinized tissue and to move it vestibularly. We make our partial thickness flap. We keep the periosteum all over the surface to be sure that we will not get bone resorption. We place our healing abutment, cover the denuded zone with pure F membranes, just suture it. Here it is. You can see that the zone of keratinization is just above our healing abutment. With the aid of this technique, we increase the thickness and the width of keratinized gingiva. And you see, this is our healing abutment. It's high enough. We place our implant a little bit subcrestal, 1.5 millimeters subcrestal. The height of the healing abutment about 5 millimeters. So we have about 3.5 millimeters of soft tissue. And you can see here the result. This is our temporary crowns. This is X-rays with temporary crowns and modification of temporary crowns to adjust the emergence profile. And this is final emergence profile, which we get after all this procedure. And you see that we keep keratinized gingiva just on vestibular side. And this is before, this is just after apically positioned flap. And the final view is what we get with the help of emergence profile modification. This is before and after of the other case. One more case, another case, more, one more case. I just collect everything together to show that how we create beautifully new zone of keratinization. And thank you very much for great attention. I overcome the limits which you gave me, but I hope you enjoy with the presentation. This is my email address, my Instagram and Facebook address. So please send your questions. You can communicate with me whenever you want. Thank you very much. I don't listen to you, sorry. What I have to do?
No,
okay.
That's all done, sir.
Yeah, now
thank you so much, sir, for beautiful session you have presented to us, and mind-blowing cases you have. Actually, a beautiful collection you have, and I was quite amazed with it. I'm quite amazed. And with this, we have a lot of regards to your lecture and a lot of questions too. So shall we move on to the questionnaire? First, the question we have from Dr. Rossitler. Where can we find more information about dynamic compression technique?
You can find the very interesting article, which very detailed, describe in very small details how we perform. And just I will post this article on my Facebook page. Please follow it, and you will see. Okay, the idea is incremental adding of flowable composite to transition zone to create the emergence profile wider and push the soft tissue in the direction we want. That's it.
Thank you, sir. And next question we have Dr. Ritesh. Can platform switching prevent crestal bone loss?
What? Yes, yeah. As I said, yeah, I understand. Thank you. As I said, by itself, it cannot prevent. If we want to keep the volume, the peri-implant bone intact, we have to have at least 3.5 millimeter of soft tissue, better 4 millimeter. So of course it helps to keep the bone, but solely by itself, without thick soft tissue, it doesn't work.
Definitely,
and maybe you will not have crater-like defect, or but you will get horizontal resorption of the bone for sure, because as I said, biological width should be kept, and it's not less 3.8 millimeters. This is biology. We cannot fight with the nature, mother nature.
Definitely. And next we have from Dr. Aishwarya. In tuberosity area, when we take CTG, what precautions must be taken in terms of greater palatine nerve?
No, in tuberosity, we cannot interfere with greater palatinal artery. It's located on the palate about 8-12 millimeters from the margin of the second molars. So we take from the tuber very safely, and it's painful and heals very fast. There is no any problems with the collecting. The only problem is to have this tuberosity zone. Sometimes the wisdom tooth occupy all the surface, and as I said, we need sometimes to extract for free, of course, wisdom tooth, and wait to create the zone for collecting soft tissue graft from the tuberosity.
So we have the next question from Dr. Markins. How can I de-epithelize gently the graft? Because every time I do, I take too much, and any tips to be given?
So it's just the question of the practice. What I can say, I recommend always change several times the 15C blades. It's very important. And then you have to keep your 15C blades parallel to the surface of the graft. If you put it under the angle, 50-20 degrees, you will cut the thickness of the graft. So you have to be parallel to the surface. You will just shave the surface of the epithelium with the new, fresh 15C blades. This is very important. Just don't hesitate to change the blades. You perform the procedure, which take your times and efforts. And now the cost of one or two blades is like, not substantial. Just encouraging you to change the blades very often. Okay?
Definitely. And next we have from Dr. Vivek. Please elaborate on tunneling technique.
Okay, this is well-known VISTA technique, which suggested by Omazadeh from University of South California. You just make on vestibular side of the ridge lower than a mucogingival junction vertical incision, and then make partial splitness flap with the help of the set of VISTA instruments, of tunneling instruments. This is special instruments which allows you carefully detach periosteum from the mucosa. And then you detach your mucosa from the periosteum on the zone where you want to graft with soft tissue. You increase the soft tissue. Of course, you cannot split in the zone of attached gingiva. Impossible. You will damage it. So you work inside of zone of mucosa under mucogingival line.
Definitely, sir. And I think we don't have much questions after this. Yeah, we don't have more questions to be asked. Yeah, we have one from Dr. Vikendra. How to do FGG on lingual side of severely resorbed mandibular anterior ridge?
Yeah, this is the most difficult question, by the way. Any procedure on lingual side are very demanding. So the same principles, but how to increase the zone of keratinization on lingual side. I just suggest not to try to make free gingival graft. First of all, try to shift your soft tissue, like I show from palatal side to vestibular. In lingual, in mandible, just try to shift the tissues from vestibular to lingual side with the help of partial thickness flap. That's the better way. Of course, when there is zero zone of keratinization and you have nothing to shift lingually, then you have to go the same type of procedure, but it's very demanding and sometimes it's very dangerous because there is a lot of there is lingual artery there, the branch of lingual artery, and you can damage it. And there is nerves which also may be damaged. So the procedure should be done very carefully. It's very demanding procedure.
Definitely, sir.
Yeah.
With this, I think
one more information. When you begin the procedure and supposed to place implant, I suggest sometimes you need to increase the thickness of soft tissue with the graft. By itself, connective tissue graft able to create new zone of keratinization because it's keep inside genetic information about keratinized tissues. Since we get the connective tissue graft from the palate, and this is full thickness flap, don't forget it. We just shave out our epithelium, and all the thickness of the graft has the information. It keeps information inside of the graft that it was sometimes keratinized tissue. So put it under the flap and wait. So prepare your implant site before going there. At least at the moment of, you can do it at the moment of implant placement or at the moment of second stage surgery, before going to second stage surgery. That's it.
Yes, sir. Thank you so much, sir. And yes, we are done with all the questions.
Thank you
And
so much.
it was quite an informative and an amazing lecture for sure.
So much. Thank you for great to share my humble knowledge with the audience. I hope everybody was attending the seminar was enjoyed with it, and I'm ready to communicate with everybody with the help of my email and through social media, which you see on the stage. Okay, thank you one more time.
Sir.
Good opportunity.
So with this, we'll move on to the end of the session, and I would like to tell all the participants to go to the site www.gomha.org for further details regarding participation certificates as well as C certificates. So with this, stay tuned because we have a lot of interesting lectures in line. So we continue and get updated with all the sessions. So thank you so much, sir. We'll move on to the end of the session. Thank you.
Mm-hmm.